So just want to, the acknowledgement of country, acknowledge the traditional custodians of the Macquarie University land, the Watamagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the Dreamtime, and we pay our respects to elders past, present and future. And then I'll just go back to the introduction screen, and Andrea is going to take over from there. And welcome everybody.
Yeah, welcome everyone, and thanks Natalie for joining us today and agreeing to sort of present to us. So I've been keen to get Natalie to talk at ISIG for a while. Natalie was actually my boss very briefly for about four weeks when I moved over to the Daffodil Centre before she moved over to her fantastic position at UNSW as an associate professor of implementation science. So I mean, a lot about Natalie's work in implementation science has been in the cancer space, including sort of cancer genomics, genetics and precision medicine, but I think you're spreading your wings wider now that you're at UNSW. And I know you do a lot of stuff around including statistical modelling and the cost effectiveness of implementation interventions. But I heard you speak briefly about the topic you're going to talk about today at another presentation, and I was just absolutely fascinated by it, because to me it sounded like such an interesting and logical thing to be exploring, which is combining intuition and theory, so using stakeholder-informed and evidence-driven methods to guide implementation. So I'm just so delighted that you can speak to us today. So what we normally do is get you to speak for perhaps half the session, and then we just open it up for questions and discussion. And yeah, so over to you, Natalie.
Right. Let me know if it doesn't move. All right. Hi, everyone. Just a bit of light entertainment for you before I begin. Yeah, thank you very much for having me to talk today. I'll miss the acknowledgement to country because Karen kindly did it. I guess what I'm going to talk to you about today are a couple of projects that have been underway for a few years now, sort of just for me to try and pursue this little passion area of implementation science. I think it's got legs. I think it's really interesting. And I think it's a really nice way of being able to help clinicians understand why theory can be important. And I think it's a really nice way as well to show them where they have a lot of experience and tacit knowledge to contribute to the design of implementation strategies. It's a bit theory heavy, but I hope it will provide some insights into what some of the detailed work behind the scenes can do to advance the efficiencies of implementation. I'd like to thank my team and key collaborators at the outset, and I have some lovely pictures to acknowledge these lovely people at the end. Right, has it moved along? So recent developments in complex intervention research stress that improving theories and understanding of how interventions interact with their context and wider dynamic systems is an equally important goal to establishing intervention effectiveness. And this quote came from the most recent MRC framework for developing and evaluating complex interventions. And to quickly just clarify terminology, on this slide we have implementation, so that's efforts to translate evidence without the use of theories or frameworks. And then evidence-based implementation practice, which is the deliberate use of theories or frameworks in this endeavour. And neither term really represents as a whole implementation science, which is the scientific study of methods and strategies that facilitate the uptake of evidence-based practice and research into regular use by practitioners and policymakers. So implementation science is really to study the things in the funnel, to understand the effects of implementation approaches so that we can advance the science and promote more efficient translation down the track. And we all know that implementation of innovations, interventions, policies and guidelines often require change in the way that people perform certain tasks, or behaviour change by healthcare professionals, which need varying levels of organisational level change and system level support. And as such, there needs to be a consideration of a range of technical, psychological and sociocultural factors when designing an implementation package. And crucially, achieving swift practice change as we try to translate evidence into practice is not only dependent on designing implementation strategies that are informed by theory, but also that align with clinical experience. And I'm sure that we all know that striking this balance can be a challenge. The ideals of rigorous driven theory approaches to implementation have often been met with significant interrelated contextual and interpersonal complexities. And these complexities present challenges for practitioners and researchers regarding staying true to a particular theoretical approach, which we know as theoretical fidelity, whilst accounting for and responding flexibly to healthcare professional, patient and system needs. These challenges are exacerbated when the intricacies of theory application are inaccessible to non-experts and slow relative to the demands for rapid evidence translation. And this often leads to on-the-spot solutions. These solutions may or may not align with theoretical recommendations, and stakeholders may also decide to enact them immediately, despite deviation from the implementation protocol. Although alternative approaches and adaptations may well be effective given the tacit knowledge and experience of clinicians, these solutions are often not recorded, making it difficult to identify the extent to which A, deviation occurred from the theorised core functions, and B, the extent to which they are effective. So one recent area of exploration is the role of healthcare professional experience-based intuition in the identification of barriers and solutions to implementation, and the extent to which this intuition aligns with theory-driven recommendations. And enhancing the understanding about the alignment of experience-based intuition and theory can tell us more about where healthcare professionals generate relevant implementation strategies, for example, education and training to address barriers identified such as knowledge and skills without the need for in-depth use of theory. It can also signal where theory is most needed, for example, to address more complex barriers such as social influences or emotion, and can be best utilised, potentially making the development of theory-guided interventions more efficient. Recording and coding these experience-based intuitive approaches to implementation strategy design against theory can allow for the study of effects, contribute to the evidence base for establishing and explaining the mechanistic links between those strategies that lead to clinical practice change, and support adjustments to theory when theoretical predications and empirical observations are inconsistent. And so just to illustrate the difference in a simple way, the diagram on the left shows what you kind of imagine a theory-guided process to address barriers to be. So we have the barrier, the theory and the intervention strategy. And then the green figure on the right shows an intuitive process towards implementation strategy design, where the intuitive approach is taken to understand and overcome barriers to practice change. So what did we do? So in this first project, it was part of a pre-post intervention study. A team of genetic counsellors aimed to understand and design strategies to overcome the major barriers familial cancer patients face around communicating hereditary cancer risk information to their relatives, and no theoretical framework was used. First, we worked with the team to review and recode barriers and interventions according to the theoretical domains framework. I'm sure many of you online know what this is, but it's a framework that specifies determinants that act as barriers and enablers that influence implementation. and provides a standardised way of defining and categorising barriers. These can be manipulated to increase the likelihood of change. As an example, an intuitive barrier generated by the team that was that families had a loss of contact with linking relatives, and the TDF domain that represented this barrier was environmental context and resources. Next, we worked with the team to review and recode intuitively developed strategies according to behaviour change techniques, or BCTs. BCTs are standardised terms with precise definitions used to describe strategies that can be designed to elicit behaviour or practice change. Following on from the estrangement example, the intuitive strategy developed to tackle this problem was to discuss that some patients have been successfully using the phone book, Facebook, or Ancestry.com to get in touch with long lost relatives. Some patients have even reported BRCA to be the catalyst to contact and reunite with relatives, and it has brought their family closer. The BCTs that represent the strategies used in this intuitive solution are information about social and environmental consequences, social support practical, vicarious consequences, and social comparison. Then the resulting BCTs were cross-referenced against the theory and techniques tool to examine whether evidence-based mechanistic links have been established to date. Mechanistic links represent theoretical alignment which has been agreed upon by expert consensus and associations in the intervention literature synthesis. Professor Susan Mickey from the UK has been advancing this work, and I encourage those interested in what I'm talking about today to play around with the theory and techniques tool and website for more information. In this example here, we can see that when the social support practical behaviour change technique has been used to tackle barriers represented by the environmental context and resources TDF domain, both consensus and evidence from the literature confirms that this is a successful approach for achieving behaviour change. But not all of the ones that I outlined just on the previous slide did demonstrate links. So in the results, 5 themes emerged from the genetic counsellor coded barriers, which when recoded according to the TDF represented 7 domains of behaviour change. 45 experiential and intuitive interventions were used to tackle key barriers. These were represented by 21 BCTs, which were found to be used on 131 occasions. And as an example, the table snippet here illustrates the intuitively defined barriers mapped to TDF domains alongside the intuitive interventions designed to overcome them, the BCTs that represented these strategies, and the level of evidence for BCT mechanism of action links. So green equals links, blue equals non-links, yellow equals evidence is inconclusive, and light blue equals absence of evidence. So 8 of the 21 BCTs identified through this coding exercise were used to address a corresponding TDF coded barrier that has previously demonstrated statistically significant mechanistic links. So that's theoretical alignment agreed upon by expert consensus and associations in the literature intervention literature synthesis. And this occurred on 13 out of 131, so 10% of occasions. For example, instruction on how to perform the behaviour is successful in achieving behaviour change when skills are a barrier. So what does this all mean? So although prospective use of theory is recommended, making links between theory and interventions explicit, even retrospectively, can contribute towards standardising intervention strategies, furthering understanding of intervention effects, and enhancing the opportunities for accurate replicability and generalizability across other settings. And I do have some more so whats, but before I go into that, I'm going to take this another step forward. So the next project where we kind of tried to advance some of this kind of methodology was in the, it was in the genomics rather than the genetic space, looking at implementing genomics across the Australian health system through Australian and Melbourne genomics. And I should also say that Steph Best had a very heavy input into this work as well. And I'm sure many of you know Steph, if she's not already online today. So this is just a quick overview of the broader implementation study design. So we applied a hybrid model 1 initially to test a clinical intervention whilst gathering information on its delivery during the effectiveness trial and or on its potential for implementation in a real world situation. So we were looking at genomic testing, clinical processes and practice implementation research, and recoding existing interview data. The next stage, we were looking at genomic testing service provision and clinical practice implementation research, and running multidisciplinary focus groups to verify barriers and facilitators to implementation and co-design interventions. I won't go into the rest, except to say that, you know, the work I'm going to talk about now is really looking at this stage 2A hybrid model 1 and stage 2B, where we're looking at a foundation intervention package and identifying measures for assessing implementation effectiveness. And this is just a snip of our study protocol. And one of the things that we used to gather this data was a process map guided interview schedule, where we had set sort of 3 main target behaviour areas for change, which was around ensuring appropriate patients receive genomic testing, the test ordering and interpreting variant stage, and then providing results back to patients. And when we synthesised the data from the interviews that we collected around this process map, we separated these target behaviours areas out so that we could understand specifically the barriers and facilitators that pertained to each of these different target behaviour areas for change. So in terms of the methods, we did interviews with non-genetic medical specialists around these 3 target behaviours. The barriers were mapped to distinct TDF domains, and intuitive enabling strategies were mapped to identified barriers. And what I mean by that is that it was strategies that clinicians had told us that they were using or could use to overcome some of these problems. We weren't directing them using theory around the design of specific strategies. So at this stage, we did in-depth context clarification and refined the TDF coding. TDF coded barriers were also grouped into overarching TDF domains. I won't go into too much detail about that, apart from just to say that anybody with experience of the TDF has probably experienced a difficulty sometimes in really attributing a particular barrier to one domain. Sometimes there are overlapping domains, and that's kind of what that area speaks to. In stage 3, barriers were mapped to intuitive enabling strategies, and these were coded against behaviour change techniques. And BCTs were also used to design implementation strategies for barriers that didn't have an intuitive strategy that had been suggested. And we also went through a process of hypothesizing mechanisms of action for both of these different approaches. And then we also identified in stage 4 intuitive enabling strategies that aligned with existing theory. So this is just an example for target behaviour area 1. Where we had grouped barriers, so for example, around gaining a belief about genomics or confidence in themselves and trust in others. We had a descriptor, which was kind of a lay descriptor. So for gaining a belief about genomics, it was that their clinicians did not understand the value of doing the test because they were too busy, it takes too long, and they lack natural referral patterns. We attributed this to the TDF domain beliefs about consequences, and one of the examples of an intuitive enabler was around seeing the results. And I'll go on into this example in a bit more detail later, but you can kind of see the example of that initial coding exercise. So if we go into this a little bit more in detail, our lay description for a particular barrier was around it's challenging to gain or grow genetic knowledge and skills because they are unable to join meetings to grow confidence, not trained to counsel, a lack of experience, a lack of genetic counselling at the offering stage to build confidence. So an example quote for this was that I'm sorry, I just can't see what I've written there. We got a report and it's something that's discussed in a meeting that I've tried to join, but I couldn't because I had no slides to look at and they were talking about slides. I've missed a few others. It's not it's an okay time, but sometimes like when our patient's being discussed, I wasn't made aware. There was a lot of information on that report, but a lot of those mutations I have never come across and I'm supposed to discuss that with the patient. How am I qualified to discuss that with the patient? So there was a couple of TDF domains here, beliefs about capabilities and social influences. And the intuitive strategies here were having knowledgeable person to ask informal questions to. So we coded this as social support practical and clinical geneticists and genetic counsellors to support. This was through, we coded this as the demonstration of the behaviour. So it has been a steep learning curve, but I suppose I think time I got very comfortable in identifying the right kind of patient, but in terms of talking to them and answering the kind of questions they would ask, obviously took some time, and I would sit in with some of the geneticists and the genetic counsellors and build, confidence that way too. So one thing that we wanted to do as we were doing this really detailed coding exercise was try to enhance the transparency in reporting for the purposes of advancing the science. So on the left, you'll see a process, an algorithm map that we created for an intuitively driven strategies, which basically shows the different approaches that can be used to understand what the barriers are from an overarching or distinct barrier perspective, and how intuitive enablers can be transformed into BCTs and eventually inform a change, or drive the change in the target behaviour. And so as an example, in a written form, we have the construct of A and distinct TDF theme B were selected because the clinicians were doing C behaviour. The intuitive enabler of D is linked to the BCT E because it will do F to change their G, distinct TDF theme, by increasing H, the overarching TDF theme, because of X, explanation. That probably makes absolutely no sense, but when you see it with it populated, which I'll show you in a second, hopefully the kind of context of it all will help to understand how having an algorithm like this and separating everything out into kind of those really small mechanistic parts, anybody can take this algorithm and complete it for themselves with the behaviour change pathway that they hypothesize or have tested and can see. So the results here of the 16 interviews showed that 32 barriers were mapped to 32 distinct TDF domains, and 30 intuitive enabling strategies were mapped to 23 of the identified barriers. In stage 2, 32 TDF coded barriers were grouped into 13 overarching TDF domains. And in stage 3, 30 intuitive enabling strategies were used on 49 occasions and coded against 21 behaviour change techniques. And we had 20 BCTs on 30 occasions that were used to design 20 implementation strategies for those 9 remaining barriers. And we had 9 or 18% of intuitive enabling strategies that aligned with existing theory. So in terms of an application of the algorithm for intuitively developed strategies, this is how what I was saying before is kind of played out in context. So the construct of decision-making and distinct TDF theme, memory, attention, and decision-making processes selected because the clinicians were confused about the process because it was not clear to them. The enabler of clear referral criteria within an informal checklist is linked to the BCT conserving mental resources because it provides explicit guidance. This should reduce the memory, attention, and decision-making barrier, the distinct TDF theme, by simplifying the process and enhancing their skills, the overarching TDF theme, for doing genomic testing by providing clearer circumstances in which to apply genomics in practice. So what does this all mean and why does it matter? So clinicians design implementation strategies that align with underlying theory only part of the time. The alignment between clinician intuition and theory was largely practical, and in many of the instances where no enabler was suggested, the barriers were more complex. In such circumstances, it may be that theory can be of greater benefit in the design of implementation strategies to address more complex barriers, for example, belief systems or emotions. So we've demonstrated an approach for combining experience-based intuition with theory to generate contextually relevant implementation strategies. Potential underlying theories made explicit to enhance transparency and efficiency. We seek to optimize iterative practice change in response to rapidly evolving scientific advances requiring swift translation into healthcare. And it took so much time, and more automated responses are needed. And so I just wanted to share with you kind of a mock-up of the toolkit, the implementation toolkit that we've designed based on all of this information in the context of genomics. So we have our three different target behaviours along the side here. And if we were going to look at challenges others have faced, if we were going to kind of present this to a group online, for example, of people who were looking for tools to overcome barriers to implementing genomics in practice, we could present this in terms of the challenges that other people have faced. And if somebody said they were too busy, then one thing that might help, if you remember earlier on, was seeing results. And there's a case study here that we have developed. So dispelling the myth of the golden ticket. Early on, some clinicians may think genomics is a passive process where you can send the test away and get a result back in a kind of ta-da way, but you have to be involved. There is a lot more art in the science than you imagine. So you are needed to contribute to that process, interpretation, and then it's not going to work a lot of the time. We've seen a lot of clinicians have these sort of light bulb moments when they suddenly get how it goes and become very enthusiastic about it and can see that they need to be involved. They are keen to be involved and they want to use the clinical skills they have to improve the process. So the theory behind the case study, we have the overarching barriers around gain belief about genomics to understand the value of doing a genomic test. Beliefs about consequences with the TDF domain. The barrier was that they're too busy. The barrier-specific TDF domain was goals and the construct goal priority. The enabler-informed strategy was seeing results, and the retrospectively coded BCT was salience of consequences. So the theorized link between the BCT barrier-specific domain and overriding TDF theme goes like this. The construct of goal priority and the TDF theme goals was selected because the clinicians were prioritizing other aspects of their role over genomics. The enabler of seeing results is linked to the BCT salience of consequences because showing the relevance of outcomes of genomics for their patients. This should change their beliefs about consequences, the overriding TDF theme, by driving reprioritization of their goals. So demonstrating how healthcare professional intuition aligns with theoretical recommendations may also demystify theory, give credit for successful intervention design and improvement where credit is due, illustrate where clinician intuition may be enough without the need for time-consuming theory-based design, highlight the additional benefits that theory has to offer and serves to promote its use in improvement, and enhance the importance of documenting strategy design. So just in terms of what next, we have the manuscript in preparation for that second study that I presented to you today. And we've recently completed a trial with 8 hospitals across 3 states, looking at theory and non-theory trial arms, where we're trying to improve referral practices for colorectal cancer patients into genetic services who might be at a high risk of Lynch syndrome. And the implementation processes are distinguished only by the use of theoretical frameworks and intuition to identify barriers and design targeted intervention strategies. And we're analysing the final outcome data now. So thanks very much for listening. These are all my lovely collaborators and team members that have worked with me on the projects I've spoken to you about today. And I'll welcome any questions and stop sharing. If I can remember how to do that.
I think it's at the top, is it, or down the bottom? You've done it. Well done.
I got it.
Thanks, Natalie. That was amazing, and so much to think about based on that. I mean, to me, it just seems so logical that we're drawing on what clinicians or whoever your stakeholders are doing or who are involved, what they're doing intuitively and leveraging off that. But then this is it. I always get slightly freaked out with the amount of theory that's going on, and I'm just wondering, how do we sort of apply this in a practical way? How can we best use what you've told us?
So I think I don't think there needs to be a huge amount of people going into the depths of despair at times that me and some of the other people involved in this work have kind of drilled down to, because I'm hoping that we've done this real in-depth work to be able to provide, I guess, at least a starting point for logging some of this information in a bit of an easier way. So actually trying to figure the information out and what an algorithm might look like, and how to piece all these different things together, I think is hopefully something that people can take on and then have a map to be able to complete the information, and an easier way and a more standardized way, hopefully, of documenting what people have used or how they have designed things, and I guess how they've played out in practice as well. I think another thing that will be helpful, I think, down the track is when we can develop through implementation science a bit more of an automated way of recording this information. And I think artificial intelligence is happening in lots of other domains of healthcare now, so why should implementation science be any different if we can start to pull that information out of literature in a bit more of an automatic way. The only thing that's going to help that is, or the main thing that's going to help that is if people record things in a standardized way and they record it systematically.
Yeah, that sounds amazing. Now, I'm just going to see if there's any questions here. Delia, do you want to ask your question? You posted something in the chat. Yeah.
Hi, everyone. Thanks, Natalie. That was very thought-provoking and very interesting. Yeah. I just sort of wondered how clinicians responded to this whole process. I may have missed it, but it's kind of quite complex. And I just wondered, how they did respond to it.
So there'd be absolutely no way, unless a clinician was desperate to see all of the information, that I would present something like this to them. I think there's only a small amount of very passionate people about implementation science that would be interested in something as in-depth as this. But I think what I have tried to do is, in a very simplified way, show clinicians to what extent their strategies are aligned with theory, and give some really clear examples of that. And I guess I try and go from the point of theory, we don't necessarily know if theory is always correct. So even though there might not be a huge alignment with some of the strategies that they've designed, it doesn't mean to say that their strategies are incorrect. It's just because they've not been tested yet. And I think I do try and go at this in more of a, we need your help to explore this together and to find better ways of testing, you know, to what extent certain strategies are effective, so that we can continue to improve the theory, as well as utilise all the tacit knowledge that clinicians have.
Thanks very much.
Karen, you've got a question there. Do you want to ask yours?
Yeah, thank you, Natalie. I think, and I was a bit worried if you had presented that detail to clinicians, because they, you know, some of that terminology and stuff might have scared a few off. But anyway, but yeah, I just wondered, because it looks like it can be translated across other clinical areas, and I just wondered if you have tested it, or the you know, your algorithms, and have you plans to test this somewhere else?
I haven't tested the algorithms in other domains, but I don't see why they wouldn't transfer across. When I started doing this work, this kind of retrospective mapping, it actually began, I think, in the stroke space.
Oh, yeah.
In terms of looking at the extent to which enablers represented behaviour change techniques. So it was really early work, probably 6 or 7 years ago, maybe longer. And then as I've kind of moved more into the cancer and genomics space, there just seemed to be really nice opportunities to kind of you know, take this approach and apply it and keep developing it. So I wouldn't say by any means it's perfect yet, but I guess it just keeps kind of evolving each time you know, we have a new kind of set of data or a new project to apply it to, and think about how we're going to co-design with clinicians. Because I think that's kind of where it all stemmed from in the beginning. I was trying to use theory in focus groups with clinicians to design strategies. And, you know, because then it's really the true art of co-design. You kind of bring in the theory in, you're using their experience, but it was too hard to, you know, to ask clinicians in very short spaces of time to grasp the concept of a particular BCT. And think about a theory-based barrier for, you know, to what we were trying to get it to overcome. And so this is kind of where it's sort of led me down this path of really trying to understand, you know, what if they come up with things by themselves? How useful is that?
Any questions from anyone else? Oh, here, Melissa.
Yeah, hi Natalie, that was an awesome talk. I was wondering if you found any of the intuitive results contradicted or went beyond and could potentially extend the TDF and what we know from the theory.
Yeah, so we did. I wouldn't be able to remember them off the top of my head, but when I think in the genetics study, and then yeah, in the genomics study, in both of them, we've indicated where there's links, non-links. Oh God, I can't remember what they are now, but there's one where it's like showing a contradiction. Basically, it's kind of saying it has a negative effect. And there weren't very many, but there are some. So I guess in terms of what you do with that, you know, maybe there is kind of a bit of a duty to you know, let people know that those things tend to have a worse effect on people's behaviour. But I don't know whether anybody else thinks it's our responsibility to do that or simply to report it.
Natalie, I was going to ask, when you presented your results, you showed that there was sort of like, it was only like 18% of the intuitive strategies actually aligned with existing theory. I mean, are you surprised by that?
No, I wasn't. I'm not surprised. I would have liked it to have been more, just for the clinicians. But again, as I said before, it's this. I think there's still a long way to go in terms of testing each of these, each of these strategies, and really finding out the extent to which they do work, because you not only are you looking at them in isolation, which is kind of a limitation of the the work that we've done. You don't know if they've been used in conjunction with other things. There's a lot of other element. We did do some really in-depth context clarification, but you still don't know a lot of the other things that are going on kind of outside that specific defined strategy that we're trying to understand. So I think it would be really interesting to try and think about ways that we can start to specifically test the impact of these strategies. I just don't know yet how you would do that in isolation.
Thank you. Erica, have you got a question?
Yeah, thanks for the talk, Natalie. Really very interesting and yeah, very technical, but also like I think a good technical. It was very, very nice to see that depth. I just wanted to know, and whether you, I may have missed whether you touched on this in your talk. You talked about AI and other ways to make this less work, but I was wondering whether you'd thought or have done any sort of prospective work. I know you said it came from the stakeholder space and then it became retrospective. Have you started, or are there any plans to start sort of prospective work where you do this maybe in a series of workshops? Just interested.
Yeah, so I guess that's sort of touching on the trial that we just completed. So in the two arms, we have one arm where we used the TDF and BCTs to drive the design of strategies with clinicians. And then in the other arm, we've used kind of focus group schedules at the same time, but we've used them kind of just in lay terms. Tell us what the barriers are, tell us what kind of things you would do to overcome them. And then alongside the trial, we've run a process evaluation so that we can try to understand in the theory-based arm, yes, they've obviously, we've guided them to use theory, but where have they deviated then? Where have they implemented things even before the strategies were designed, or when have they done something different after the strategy design or implementation? And then the same with the intuitive side of things. We've really tried to understand all along the way where people may have done additional, I guess, different things that weren't kind of formally recorded as part of that kind of strategy design session. So we are, again, like just edging it forward slightly each time to try and discover more. But that's as far as we've got so far.
Yeah, so interesting. Thank you.
Lauren, do you want to ask your question?
Sure. Thanks, Natalie. I was just wondering, your algorithm, and especially thinking about bringing AI and data into it, it almost feels like, you can kind of plug in your problem and get handed a solution. But how much do you think, especially with co-design, obviously it enables you to tailor your intervention to the context.
Yeah.
So I think you were working across multiple sites, were you? I'm just wondering how much, whether there was agreement over sites or whether it really was a very context specific exercise.
I think with the interviews, we did do it over different sites and in different states, and we didn't make any distinctions. I guess the themes came together as the themes, and we didn't make a distinction between context at that stage. However, I think going on to do more work with rural and remote sites in the genomic space, I think that there would be some differences, not necessarily in the barrier, you know, there would be barriers and enablers that would be different, but I think the algorithm could still apply. I think we'll probably, what I see in terms of the AI potential is to also pull out that information. So pull out information about context and to see then whether or not context does make a difference to the types of barriers and the intuitive strategies or theory-based strategies that people are using. So again, thinking about it, but not quite figured out how to unpick it in enough detail yet.
Thank you.
Now, I was interested, you were saying that one of the benefits might be in sort of being able to identify where clinician intuition would be enough without having to sort of add on, you know, the time-consuming theory-based design. Have you got any sense of, you know, how would identify those scenarios where we could just go with, you know, clinician intuition rather than drawing on the theory?
I think if you were to be able to understand, perhaps using a theory-informed framework, what the clinician barriers are to a particular behaviour change, and you've probed around some of the more complex barriers like social influences or emotion, and nothing is drawn out based on those things, and you know, you firmly believe that they're not hiding anything, then, you know, and that things do come out around knowledge and skills, which tend to be, you know, a little bit more simple to solve with education and training and provision of information, then, you know, that, I guess that's, I wouldn't kind of say, oh, I definitely recommend that, but that's probably as far as I would go, in terms of sort of saying, you wouldn't necessarily need to, they could probably come up with their own strategies.
Yeah, great. Any other questions?
I have a question.
Oh, go Sam.
Thanks. That was wonderful. Thank you, Natalie. My question was, if this intuitive driven theory was to be replicated, what would that look like? Would it be sort of a process of creation again from, you know, the start, or would it be kind of applying what has been found and making iterations to, you know, based on the specific context, if that makes sense?
I think so. I guess for me, it really, at the moment, it boils down to how can we align, how can we use the intuitive ideas that clinicians come up with, and whether it's aligning it with theory or whether it's just standardizing according to specific theoretical definitions, constructs, behavior change techniques, that to me is, there's two advantages of theory. One is that the kind of descriptions are standardized, and so everybody could term things in the same way, and that helps people to replicate. If it works, people know exactly what worked and why. And also, with, you know, if you term it in that way, then that's where you can start to actually test links. Obviously, it's quite difficult in the implementation phase to do that, but that's, you know, that's the way to be able to kind of formally test whether a particular intuitive strategy that's defined in a theoretical way actually causes a change in the behavior that we want to see. So I think that for me is like at the moment the great use of understanding more about intuition, and kind of advancing the science. I wouldn't want to be sort of suggesting that we have to generate a whole new you know, kind of a whole new extra thing for everybody to do. It's, you know, I guess I'm hoping that me and, you know, people who are on my team or interested in doing this are kind of doing it to advance the science so that other people don't have to do it.
Yeah, thank you.
That would be the goal, wouldn't it? Just to simplify things, even just slightly would be great. Nat, that's been absolutely amazing. Thank you so much for coming and sharing that with us. And I would love to have you back later on when you've done a little bit more work in this area and could report back. But that was fantastic. So thank you. Our next meeting is, Nat, sorry, I cut you off.
I was just going to say thank you for having me. And I know that I might have bumbled a little bit in places because it is quite complex, and even in my own, head, I'm sort of like, but I hope I didn't confuse anybody in any places, and if I did, please feel free to reach out and ask any specific questions or clarifying questions. I'll do my best.
I just think it's lovely to see how you've sort of so meticulously worked through it all, and used the different theories. But I think the end goal, obviously, trying to be that we can simplify things in some ways. So I think that is amazing. So our next meeting is, I think it's September the 26th. Is that right, Karen? And I'm not 100% sure if we've lined up a speaker for that yet, but we will be letting everyone know in the weeks beforehand. So just thank you again, Natalie.
Thanks for having me. Thanks for listening.
Thank you.
Thank
and
you.
Thanks everyone for joining us.
Thank you.
And we
Take
look forward
care.
to seeing you all next month.
Thank you. Bye.
Bye.